in the brain, pancreas, GI tract, and so forth. So the problem with diabetics is they have this decreased insulin response. They it may be because there's reduced beta cell in the pancreas, so there's not enough cells to no matter how little they do maintain function. So how do we solve the problem? We treat with more GLPs. So the basic benefits, they decrease hemoglobin A1C by 2 points almost. They decrease body weight, decrease systolic blood pressure, little increase in heart rate, but that has not been shown to be detrimental, and decrease the LDL and triglyceride modestly. Okay, so in this STEP trial, there's been a lot of trials on them, and I'll share them as I go. This is at the end of a 2-year trial when compared to placebo with intensive diet and exercise versus people on the maximum dose of semaglutide, 2.4 milligram. There was a 16% reduction in body weight, which is significant. We're happy to get 5% reduction in body weight. So this is huge, and it has played a huge factor in obesity treatment. So common side effects, they're usually GI because, they slow down gastric emptying. So it translates to some people as nausea. And it's usually transient. That's why we usually start lower dose and work up. And that can be curtailed also by eating smaller meals, and avoiding fatty foods. And another side effect is headache. Mostly, I think, because patients are not hungry, they may not be drinking enough water. So usually that's curtailed with an increase in the water intake. Cautions. So these are the things GLP-1 do not cause pancreatitis, but we have to caution in patients with history of pancreatitis. So the trials did not show any association with pancreatitis or pancreatic cancer. There's some concerns for retinopathy, and it might be due to the marked glycemic improvements as usually seen with insulin, and medullary thyroid cancer, which was only seen in rodents, not humans, but patients with family history of the MEN syndrome, medullary thyroid cancer syndrome. This should not be used. It's extremely rare. In my 20-year career, I have never met anybody with this. And acute cholecystitis, which there's some reports. So these are the major players. They're injectable pens that are available, and patients can dial the dose and self-inject. And these are the common ones: liraglutide, Victoza, and Saxenda, and semaglutide. These are the brand names: dulaglutide, and the new one that's tirzepatide that has both GIP and GLP effects. So there have been a number of trials, and the good thing about this, it has shown a lot of cardiovascular benefits. And you can see for major adverse cardiovascular events, there's been a significant reduction in these studies. So if you don't get anything, please, this is my take-home slide. And that's why there's such important benefits in diabetes and obesity, is this decrease in cardiovascular risk. And these are the different trials. And again, MACE stands for major adverse cardiovascular events. There's been decrease in most of them, and particularly liraglutide, 13% decrease in MACE, semaglutide even more. and dulaglutide, and decrease in cardiovascular death, which is significant for liraglutide, and oral semaglutide as well. But this study was not statistically significant. And then non-fatal stroke, semaglutide and dulaglutide has shown effect, and all cause death. So more take home. So GLP-1 receptor agonists are preferred in patients with type 2 diabetes, and especially with ones with cardiovascular disease or at high risk for cardiovascular disease, which is all diabetics really. And they're preferred in patients with diabetes who especially need to lose weight. And these are the other players, the SGLT2 inhibitors, but I won't talk about that. So take homes. So primary prevention of cardiovascular disease is dulaglutide. In that study, the patients were not, they didn't have a history of heart disease, but they've shown reduction in cardiovascular disease. So that's why they got the primary prevention. And then the others have secondary prevention of cardiovascular disease, liraglutide, semaglutide, and dulaglutide. And for obesity management, liraglutide, which is Victoza, semaglutide, Ozempic, and tirzepatide, Mounjaro, have been FDA approved for obesity management. So I know what you're thinking. Well, we're in Sierra Leone. We don't have access to GLP-1s. What do we do? And I think these drugs are worth fighting for. So because of the marked cardiovascular benefit. So in my practice, I have a weight loss clinic that I run on the side in addition to my primary care practice. And we find ways to get this available because the drawback is they're very expensive, and they're indicated for diabetes right now. And they're insured, we have a hard time with insurance coverage. And then for weight loss, it's even harder. So we have found benefit with compound semaglutide, which we can get, a modest rate of $150 to $200 per vial. And they're usually, if you start the lowest dose, they're about 20 injections per vial. So what we do for these patients is bring them in once weekly for injections. So, they come every week, get their injections week to 2 weeks, and it's become a little bit more affordable. So let's say in Sierra Leone, let's use the cheapest price that I could find, $150. You divide it into 20 doses, that's about $7 per dose. And that comes about 150 Leone. So for middle class, it may not be too bad if they, want to lose weight, improve their diabetes, and it's it's worth it. That's it. Any questions?
I have a question.
For the
Sure.
sake of, for the sake of time, we'll take 2 questions. Anyone have questions?
I have a
I have
question. Hear me?
Yeah.
Dr. Attipoe, can you get those combined medicines for use in Sierra Leone? Is it possible for Sierra Leonean physicians to get them from US?
Yes.
Because
You can order them online and maybe have someone ship them, somebody like Dr. Fuad, who has a pharmacy. And the doctors can buy it in bulk in Sierra Leone and make it available in their office.
well, I would caution ordering medications from online. Is it possible for you to get them for like doctors in Freetown?
Right. Yes, that's what I'm saying. We would have to order it. Well, this a good point, because you can't trust all the pharmacies. I order from a trusted compound pharmacy, and I've been using it in the patients, and they have similar side effects to Ozempic, the Ozempic brand. And so once you get a trusted pharmacy that you can order, and then have it shipped to Sierra Leone.
Excellent. Because I would just see the benefits. I had a patient recently who needed knee surgery, but like she is like 250 pounds, and the doctors wanted her to lose weight, and she started using Ozempic once a week. Within 3 months, she lost 40 pounds. And I could just see all the cardiovascular benefits and all the benefits just within that 3 months of weekly injections. Thank you. Great presentation, Dr. Attipoe.
Thank you. Anybody else?
Thank you very much. That was a very brilliant presentation. I am a pediatrician, so I am coming from the pediatric point of view. We do have adolescents who come down with diabetes, but most of the time they will come down with type 1 in DKA. But rarely you have some who come down with the monogenic diabetes and MODY, for example, of which we have various variants. And it's usually a struggle to manage MODY because the drug of choice is usually the sulfonylureas, which have problems with weight gain. And most of the children who come down with MODY are usually obese. So it's very problematic managing MODY. And sometimes you have to resort to using insulin with all the challenges. So I'm just wondering whether the GLP-1 have been tested in children, specifically adolescents with MODY, and what is efficacy? And could it be used as an alternative to the sulfonylureas or to insulin in managing children with MODY?
Good question. Really excellent question. So for now, in the US, it's approved for children 12 and above. So it's safely used in children, and I have a few patients in the pediatric population who I'm using it with, and it works really well. So with MODY now, and patients with type 1, it's not FDA approved yet, but we still use them because of you don't really need to be a diabetic to use this medication. So I would consider that highly on those MODY patients.
Thank you.
Yes, thank you, Dr. Francis. My question is about Ozempic. I know it's very effective with the treatment of weight loss and diabetes, but my concern is storage, and it has to be refrigerated. With the inconsistency with electricity here, not that I'm saying anything negative about electricity, but the possibility of having constant electricity is very
in the clinic and injecting, having patients come in for weekly is an option, or patients who have, a generator in their houses, they could also self-inject once trained.
So for the initial storage of the cell for the GLP-1, that's when you need temperature, cold temperature. After the initial use, it could be at room temperature. It doesn't need to be refrigerated. Okay, initial storage transition, you need refrigeration. After initial use, you don't need refrigeration.
Thank you very much. And just 2 quick points regarding efficacy of the drugs. I think in pediatrics, you can extrapolate efficacy or not safety. So maybe we need to do more studies after the clinical trial for 14 years. But back to my local context, so in terms of energy, the good news that Sierra Leone we are going green. Recently, we have established 6 hospitals with solar energy, which means most of the major hospitals, PCM, private hospitals, and others, we commissioned 6 of them. So we have solar all year around. We are using the solar energy in that part of the world. So sustained energy should be safe for the past very soon. we are even as ambitious as going forward as going to be using our storage house for the medication. It's going to be solar powered. So we have continuous energy supply. And even some of the boats will be using the riverine areas, it's going to be solar panel powered. And so ambitious that we are going green in Sierra Leone. So that's a good way. And ambulance for the solar.
Thank you. This should be the last question. Thank you.
Thank you very much, Doug. I'm Dr. Christine Williams, a specialist physician. The first part of my question has been answered. The second one is about the benefits of GLP-1 antagonist. I want to know, after you stop the medication, will the cardiovascular benefits continue? Secondly, is there any study in combination with SGLT2 antagonists? Because we know that's another new kid in the block, and we use it for heart failure and patients with diabetes. So I just want to know if you can use this in combination and if there is additional benefits when you use them together, or you should not. Thank you.
Thank you for your question.
Thank you. Good point. So there is some weight gain once the medications are stopped. But I think the benefit with the GLP-1s is that they have that behavioral aspect with food. Even if they gain weight, it's not back to their baseline. So the studies do show that you have to continue them for some time. And I think initially when we started, we said 3 years, but now, there's no limit. But it takes time to get that behavior, so what I see is in my practice, there's a different relationship with food now. So once you've taken these meds for a while, even if you gain weight, it's not going to be the same as before. And you're not tempted to eat as much as you used to because you've been, trained. I think it really works in the brain to help with that. Then the second question, yes, you can use it in combination with SGLT2. There's more cardiovascular benefit. I touched on that briefly. In patients with heart failure and chronic kidney disease, there's indication. So now the take homes is just GLP-1s and SGLT2s, for all the benefits. And we're using less and less insulin because of these medications.
Thank you so much, Dr. Fredisia, for waking up early out in East Coast and joining us. Guys, please give a one of them.
Thank you. Thank you.
Our next speaker is our chairman, Dr. Michael Pierre, whose topic will be on cirrhosis with the primary care approach, screening, immunization, lifestyle modification. Dr. Pierre? Yes, it's coming slowly with the sound.
We decided to talk about cirrhosis of the liver because it is a very important topic.